Hi, my name is Dr. Ross Hauser. Welcome to Caring Medical Florida. We're actually going to talk about what I think is a really interesting topic, which is pupil dilation and constriction. There's lots of people who know that they feel better in a dark room, right? They feel better in a dark room. They might get migraine headaches and they just feel better in a dark room. Or they have to wear sunglasses, they actually have to wear sunglasses, or they don't go out in midday because the light bothers them. The light might bother them, like I said, giving them a headache, giving them neck tension. They could get fatigued from the light. They can't read. And a lot of this is actually a problem with the nerve impulses to the muscles that constrict or dilate the pupil. The pupil is supposed to be dilated when the room's dark, but there's people, because of cervical instability, the pupils stay dilated. So that would mean that when it's midday and there's a lot of light, like right now there's a lot of light, the pupils are supposed to constrict. So imagine if your pupils stay dilated, it would hurt. And then it could also then trigger a reaction, a neurologic reaction, where you get vasodilation of the blood vessels in the brain and get a really bad headache. Well, it turns out the main nerves that control the pupils are the sympathetic nerves from the superior cervical ganglion. So when those nerves give input to the pupil dilates. So the pupil dilates. Now, the nerve input that actually constricts the pupils is twofold. One is the oculomotor nerve, which is cranial nerve 3. But what we find in the office of people who their pupils stay dilated, even when I shine light in them, they are sluggish to respond to light. That's how you diagnose it. Like anybody watching this, you can diagnose it yourself. You can turn the lights out, then get a flashlight, then shine a flashlight in your eyes, and you might find that one side, the pupils don't constrict as much. So that would mean that on that side where the pupils stay dilated compared to the other side, that you have too much superior cervical sympathetic ganglion input on that eye, which is normally due to inadequate vagus nerve input on that side. That's actually what causes it. The vagus nerve is what inhibits the nerve impulses of the superior cervical sympathetic ganglion. So when a person has upper cervical instability, it can affect the functioning not just of the vagus nerve, but the superior cervical sympathetic ganglion. The cell bodies of the vagus nerve are in the nodose ganglion, which sits right in front of C1, and the nerve cell bodies, like the brains of the superior cervical sympathetic ganglion, sit right on the anterior part of C2, right in front of C2. So vagus nerve right in front of C1, superior cervical ganglion right in front of C2. So if a person has upper cervical instability, you can see that it could easily affect the vagus nerve, and then if the vagus nerve doesn't inhibit the nerve impulse of the superior cervical ganglion to the pupils stay dilated. And of course it could be on both sides. So when a person has that, they're very, very sensitive to light, so they just want to stay in a dark place, or they wear sunglasses all the time. So if that's you, or you know somebody like that, you have to consider getting a digital motion x-ray. The digital motion x-ray is the best way to document C1, C2 instability. If upper cervical instability is found, then the prognosis is good for resolution of this by prolotherapy. Prolotherapy injections given to the posterior ligament complex in the stretched out ligaments causes them to tighten. The tightening process takes anywhere from 3 to 6 months. So there's a series of sessions needed, anywhere from 3 to 8. But the good news is the light sensitivity that occurs with this condition can absolutely be cured.